Okay, hello everyone, and welcome to today's webinar, sponsored by the Northwest ATTC, the Pacific Southwest ATTC, and the Western States node of the NIDA Clinical Trials Network. I'm Riley Vest, and I'll be your host for today, and we're very excited to have Nancy Roget, the Executive Director of the University of Nevada, Reno Center for Application of Substance Abuse Technologies. We also have the pleasure of hearing from Mary Ellen Evers, a licensed clinical social worker and certified advanced alcohol and drug counselor. Today, they will be talking about the effectiveness and utility of telebehavioral services or telehealth. The future is here. So I'm going to go over a couple of housekeeping things. First, if you have any questions for Mrs. Roget or Mrs. Evers during the presentation, you can put them in the chat and we will answer them throughout the presentation as well as after the talk. You'll also be getting an email at the end of today's webinar that has a link to a survey in it. And we ask that you please take this survey as it helps us to make sure that we just continue bringing content that you're interested in. That email will also have a link to download the slides from today and a link to the Northwest ATTC website, where you'll be able to find a recording of the webinar later this week. Additionally, when you registered for today's session, you marked the type of CE or CME credits you are interested in. For CME credits, you'll receive an email with instructions on how to log into the Stanford CME portal, as well as some other instructions. And this slide just has some information about the CME accreditation. If you selected one of the types of CE credits, you'll receive an email shortly after the session with instructions on how to receive those. And all of this information is in the slide, so no need to write anything down right now. And those of you who requested a certificate of attendance will receive that automatically via email in about a week. Okay, so now on to speakers' introductions and webinar. Nancy Roget has 43 years of experience providing SUD treatment services, creating innovative educational initiatives and curricula. She has worked at Reno Center for the Application of Substance Abuse Technology since 1993 as a principal investigator project director for numerous federal and state grants and contracts, including the Regional Addiction Technology Transfer Center. In 2012, she established the National Frontier and Rural ATTC. Currently, Nancy is the co-director of the Mountain Plains ATTC in partnership with the University of North Dakota. Finally, since 2012, Nancy has focused on developing training and products that promote the use of digital health technologies for SUD treatment providers and peer support specialists. Mary Ellen has been providing therapy for over 25 years. In addition to being a treatment provider, Mary Ellen is a trainer and educator in the use of telehealth treatment. She is considered a subject matter expert in telehealth from the state of Florida and has worked with the Florida Certification Board, the Addiction Treatment Technology Center, and the Frontier and Rural Addiction Technology Transfer Center. Welcome, Nancy and Mary Ellen.
Thank you very much for that kind introduction. I have to apologize to everybody. I have a pretty nasty cold, but wanted to make sure that I made it to the presentation since it's been in the planning for a long time. And I'm really excited to work with my colleague, Mary Ellen Evers. Mary Ellen?
Nance, great to see you again. Riley, thank you for inviting me. Yep. Over 100 people here so far, so it's great to see all these participants logging on and joining us for this. So happy to be here. Thanks.
Okay, well, we'll get going. Okay, Mary Ellen, can see the right screen, or do I need to flip it again?
You need to flip.
All right, let's put it in PowerPoint mode. How's that, or flip it again?
Nope, flip it again. You need presenter mode.
There we go. How's that?
Perfect.
Okay, great. Well, welcome everybody. You will get copies of our slides, and so no worries about taking notes. And we're going to go through the material pretty quickly. We wanted to show you that we are associated with the Pacific Southwest ATTC. We work with Tom Fries and Beth Rutowski, our colleagues, and we also are partners in the Region 8 ATTC, and we've done some work with Region 10, ATTC, and with the Western State nodes in the past. So it's kind of like Old Home Week. So we're excited to continue our work. And here's a brief outline. I'm not going to go through all the different bullets, but we'll be covering a lot of topics today related to telebehavioral health, or telehealth for short. And I'm going to start us off with talking about the research base for telebehavioral health. And then we'll go in and talk more about clinical aspects. And Mary Ellen can certainly share her wealth of knowledge and experience in doing telehealth. So we're gonna make the case for telebehavioral health. So what we're talking about in telebehavioral health, we're talking about synchronous, meaning live video and audio, and it has been found to be effective, well received, and a standard way to practice. And certainly with the onset of COVID, we saw this huge increase in telehealth, in the utilization of telehealth, so that our clients and patients could continue to get treatment services. Very important not to interrupt those services during COVID. A lot of folks say, oh, well, telehealth is brand new. Well, actually, it's not. It started in 1959 at the University of Nebraska, and they were using video conferencing to do education, research, consultation, and group treatment, believe it or not. And then these are actual pictures from the 1960s where they were showing a telemedicine clinic at Boston's Logan Airport. So they were transmitting from the airport back to Massachusetts General Hospital. So telehealth has been around for a long time, and it's always suffered with its successful implementation. But let's go over some of the data, because now we have much better data, especially regarding treating substance use disorders. So delivering manualized treatment via telepsychology can be just as effective as face-to-face. Okay, and let's see here. There's a great systematic review of video conferencing, and basically here's some of the highlights from the systematic review. It's ease of use, improved outcomes and communication, it improved medication adherence, it decreased missed appointments, wait times, and readmissions, and patient travel time. Absolutely. Okay. Mary Ellen, I'm going to try and get rid of this box because it kind of interferes with our pictures here. So that's better. Okay. How about that?
You stayed the same, so it must just be on your end.
Okay, great. Part of the issue we want to talk about here is that patients report high levels of satisfaction. That's a really consistent finding if you look at the literature. In all patient populations, children, adolescents, seniors, minority populations, individuals in the justice system report satisfaction with telehealth. This is a recent study that was completed in 2020, and it was people who participated in group counseling, virtual group counseling, and they were like, well, you know, I don't like it as much as in person, but man, the convenience of attending group online, you know, made any barriers go away. I might not have been able to attend group if they hadn't offered these online sessions. And while it wasn't my first choice, this is the participant speaking, it was preferred over no treatment at all. Now, when we talk about providers, and Mary Ellen and I will be talking about providers in more detail, while clients and patients reported high satisfaction, they liked doing video conferencing, providers had more concerns about doing video conferencing or telebehavioral health. So what you have is reluctant providers rather than reluctant patients. And here's some of the concerns that clinicians had using new software programs or technology, confidentiality, privacy, and security issues, questions about telehealth's efficacy, and then regulatory concerns. What are the laws governing telehealth, or what are some of the roadblocks? And this was a study done in 2018. More recent study, you can see here, all these little placards in the picture here show some of the difficulties or concerns that clinicians had regarding using telehealth. I'm not a tech expert, right, Mary Ellen? We've heard these.
Gosh, yeah, so many of these.
I feel limited by the technology. What about not being close to the client? Is it difficult to project empathy? Unsure about eye contact. Sounds
I'm
like
gonna miss their
telehealth.
nonverbals. That was a big one too. I'm gonna miss nonverbals.
Right, right. And this is some of the questions or comments you hear when you do trainings for us or when you teach our academic course on telehealth. Is that right?
Yes. Mm-hmm.
Okay, great. So how, and actually, you know, counselors or clinicians having negative attitudes about telehealth, man, it goes way back. This was an interesting study done in 2005. And so they took 30 psychologists and they divided them into two groups, and 15 psychologists viewed a video of an in-person session and rated the therapeutic alliance. And the other 15 psychologists viewed a video of a telehealth session and rated the therapeutic alliance. And the telehealth session was rated lower in a therapeutic alliance, even though the sessions were the same. All right, so it's just those like, oh, well, you know, telehealth is not quite as good as in person. Okay,
It's
so
almost that self-fulfilling prophecy. This isn't going to be as good of a session, and it ended up being rated less of a therapeutic alliance.
Right, even though it was the same session.
Yep. Mm-hmm.
So how do you address these clinician attitudes? What we have found, what the literature has found as well, clinicians with more telehealth knowledge and experience have more favorable opinions. Mary Ellen, do you want to tell the story of when you were told at the big Florida treatment program that you were going to do telehealth?
Which one? I'm sorry. You're recalling one of my.
What they said to you what you said when you heard you were going to have to use telehealth at the Florida program.
Oh, at that nursing home.
Yeah.
Where they would, yeah, it was a horrible, this was early telehealth experience where they would roll people into a little broom closet pretty much at a nursing home. And they wanted me to do teletherapy with elderly nursing home patients with this idea that an aide would be seated next to them, and they rolled in these elderly people with their IV poles, and staff was sitting there, and these folks were like tapping on the computer screen. They were confused where I was coming from. It wasn't a real good setup. So because of that, I decided not to do it back then.
Right.
For ethical and legal reasons.
Yeah. What changed your mind?
Of not doing it?
Of deciding to be more in favor of telehealth? Was it your experience in
so years later working with my colleagues in Florida at Operation PAR, and we started to provide teletherapy and telehealth. It was kind of like a field of dreams, right? If we build it, they will come. And so we built it, and we created a teletherapy option, and they came, and they kept coming, and they discovered, yep, and they discovered that there was fewer missed appointments, and people were engaged in treatment longer. And we know with longer treatment comes more success and recovery. So, you know, it started to expand and became a part of treatment even before COVID.
Yep. This recent article by McClellan found that increasing knowledge and promoting skill proficiency may be a key to more widespread adoption of telehealth, and then practice, as with any evidence-based practice, right? Practice
Absolutely.
with feedback, observing colleagues, and accessing experts to help build competency. It also fits for telehealth skills, okay? Not just motivational interviewing or other evidence-based practices. What we like to remind folks of is that telebehavioral health doesn't change how a clinician provides services, but most of the burden is on the clinician rather than the patient. Let me back up here. Okay. And really what, we kind of, Mary Ellen and I talk about when you're doing, let's say you're doing outpatient services in a clinic and you're a clinician and you greet your patient in the waiting room, you walk them back to the room, the counseling room, you do your session, right, Mary Ellen, and you then walk them out, they pay their fees, you've rescheduled your next appointment, and then you sit down and wait for your next patient after you maybe make your clinical notes. And but all the effort of getting to the clinic and all the burden is on the patient. Got to take off work, got to get childcare, got to get transportation. And with telehealth, the burden is sort of flipped. And
Absolutely.
That's what this picture represents. Would you want to comment some more on that?
Yeah, please. Thank you. I always joke about when I had my brick and mortar practice here. I'm in Pennsylvania now. I know I alluded to Florida. I'm up in Northeast PA now. Go Phillies. When I was in my practice, pretty much I would sit there and play Candy Crush or Scrabble or look at my phone until my patient showed up for their session. I didn't have anything else to do. They came to me. Very different with telehealth, right? I have to send out my link every morning so that the folks can log on. I've got to set Zoom up for each and every meeting in the morning before the day even starts. I've got to kind of assess their comfortability and ability to use the computer and the internet. It is a lot more work on my end. And so the burden does fall on the clinician compared to when it was the face-to-face sessions at my office when I would just sit there.
Yep. So why should we continue to use telehealth? Whether it's clinical services, peer support services. Well, this was from the SAMHSA National Household Survey on Drug Use and Health. And this is the 2020 survey. They just came out with the 2021 results, and they're very similar, but I like the slide that they showed. But you can see here, we have under 10% of the people who had a substance use disorder in the past year got any kind of treatment services. And part of the issue is telehealth can increase access to services. Then we have to make it easier for folks to get into treatment. And that's one of the whole premises of what we're talking about today. And what we're trying to do is help people understand that they can deliver services, clinical services, and recovery support services, but we're focused on clinical services today, using telehealth in order to increase access. Okay, now, why do we say that? Well, there's been some major changes, Mary Ellen, in the last, in the last 10 years. In 2011, only 35% of the US citizens owned a smartphone. Now we're up to 85%. And this allows folks to be able to use their phone to receive and participate in telehealth services. Mary Ellen, do you have, whoops, I keep hitting the wrong button. Do you have folks that are continuing that use their phone for their session with you?
Absolutely. I have a number of people who, whether it's their lunch hour, will sit in their car for privacy, will use their phones for their sessions because a lot of people don't even have computers anymore, right? They do everything through an iPad or a phone. I kind of chuckle at that, the Pew data about the 344 times a day the smartphones are checked in the United States, because if anything, I've learned to instruct my people to put on their do not disturb on their phone before they log into their session with me, so that we don't get interrupted with various text messages and phone calls. So yeah, it's the heart and soul of a lot of folks, their smartphones.
Right, and people use their phone, the note here about 344 times a day. People use their phone all the time. And if you talk with Gen Z or millennials, more than likely they're not going to have a laptop at home. They'll have a phone or tablet that they're going to use. Okay, so more access to phones, to smartphones, and so the ability to participate in video conferencing or telebehavioral health has increased. Okay, I'm going to take any questions that folks have right now before we dive into the more clinical piece of our presentation. Riley, I don't know if you have any.
I do. I have a couple here. The first one is, with the move to better and better technology, do you see a role in the future to virtual reality-based therapy?
That's such an interesting question, because AI is huge nowadays, and there's some new amazing avatars and things like that that are out there. We're never going to, my belief is we're never going to go away. I think people in general, if anything, COVID taught us we crave the human touch, so to speak, and folks can feel that through the computer. I don't think technology is going to make us completely go away. My opinion.
Yeah, there's some interesting research out now using virtual reality. There's some research with veterans called Guardian Angel to help with trauma and anxiety. We know some treatment programs in Iowa have been using virtual reality programs with their patients, and so they do their sessions, their group sessions using virtual reality. And so I think we're going to start to see a lot more use of different types of technology. And I think we'll talk about it at the very end, but Jay Shore, who's a leader in telebehavioral health, he's a psychiatrist in digital health, really talks about hybrid use and that services will have a hybrid delivery. So we'll do some sessions in person, some on the phone, some using video conferencing, and my guess is some using virtual health.
Okay, thank you. The next one will be, will you be discussing legalities of client location versus therapist location?
We'll talk a little bit about that. So far, Mary Ellen, we can say that most states determine, it's where the patient resides. So you have to be licensed in the state in which the patient resides.
Okay. The very last one that we have right now is, what's the best way for privacy from other family members listening or manipulating responses?
That's a great question. I mean, we can get a little more in depth with that. Off the top of my head, again, when you work with kids or adolescents, it's different, but anything you can do to separate the person from the family member so that they're not going to interrupt them. As I mentioned, I have folks who will sit in their car, so to speak, to have their session for privacy. There are some situations with adolescents I've worked with where I've had to sit the parent down and say, this just is not a viable option for you and your child. And then I would refer to face-to-face.
Headphones, right?
Headphones are a piece as well. Again, though, they can hear what the person is saying.
That's right.
So at the most, it's just trying to find some area where the person's absolutely alone and the parent or the family member can't barge in.
Okay. Thank you, Riley. We're going to move on because we have a ton of material to get to, and we're heading into some really interesting issues, clinical issues.
Okay,
So
perfect.
we're going to be talking about engagement, presence, and therapeutic alliance, and then we're going to head into telepresence, which is one of Mary Ellen and I's favorite topics.
Yep.
And what we want to do, a quick review, is like, obviously any therapeutic relationship, engagement is so important, and it's the key for effective treatment. And I don't think Mary Ellen would get any argument on that, right?
Absolutely no argument.
And then here's some definitions. Patient engagement is the degree to which patients actively participate in their care. This is a definition from NAMI, and I can read this to you. I'm sorry, I'm reading it for folks that have called in. I don't mean to be repetitive for the folks who are online. The strength-based process through which individuals with mental health conditions form a healing connection with people that support their recovery and wellness within the context of family, culture, and community. And that's part of the therapeutic alliance. This is a great quote, and I think
love
Mary
this quote.
Ellen, go ahead and talk about that if you want.
A clinician's highest calling is to comfort others in their suffering, a fundamental contribution to our own sense of purpose and meaning in our work. While there is no standard definition, we identify presence as undistracted healing, with undistracted accented there, engagement between the client and patient. And what I love about this slide and specifying this concept of undistracted healing is that people have discovered with telehealth, clinicians and clients, that you could easily get distracted. I could have my cell phone next to me. I could have a TV on beyond my computer screen, as a client could. And my responsibility as a clinician is to not be distracted and just be here with the folks I'm working with, even though we are not in the same room.
Absolutely. So presence in counseling sessions, it enables therapists to be physically, emotionally, cognitively, spiritually, and relationally in touch with themselves and their clients. And presence is a crucial factor. It allows psychologists, this was a study with psychologists, and clients to connect by experiencing the same moment. And so really what we're talking about here is we're setting the stage for talking about how do you create this therapeutic relationship, this therapeutic alliance in a telehealth setting, because all the literature supports having therapeutic alliance. In fact, we know many research studies actually test therapeutic alliance with a patient being able to evaluate the level of therapeutic alliance created by the counselor, right? So a therapeutic alliance has three critical factors. You need to share your expectations and goals, both the clients and the psychologists, a clear definition of responsibilities, rules, and commitments, and a relationship between the psychologist and clients that involves their bonds, mutual trust, and respect. And none of this is different in video conferencing or telebehavioral health. It just may be done differently. Would you agree with that, Mary Ellen?
I would, without a doubt. You know, one of the words that always sticks out to me from that earlier slide was just that safety. Folks need to feel safe. So, you know, we'll often use the term that telehealth is the same but different than face-to-face. You can walk in my office and see what's around. At times, what I've done, if somebody does feel uneasy, is I will run my camera around the room I'm sitting in my basement to show them what's around. So this is where the work is a little more on the client or on the clinician as well, but it's doing certain things to help with the client feeling safe and comfortable and mutually respect that this is where I'm at and I'm by myself.
Yep. So the goal of technology is to simulate real-time experiences related to feelings, perceptions, images, and interactions. And it's to create this environment that facilitates therapeutic engagement and building of the therapeutic alliance and emotional well-being for all parties. And you can see here, Mary Ellen, we use this thing because it's not a perfect science. I mean, sometimes you get it right on and sometimes it's like close, but our whole goal here with telebehavioral health is to recreate clinical sessions as if the person was in the room with you.
Yeah, and I can share just a real quick anecdote there. You could see any more, Nance, right? I sit on my couch when I do these. I used to sit in an office chair at a desk with the screen behind me, but it was still an office desk. And I had a small injury on my foot and I needed to sit with my leg up for a few days. And interestingly enough, my clients gave me feedback how much they loved the new setup and that to them it felt more like my old office where they would sit on a couch and I would sit in a chair. And the only time I sat in an office desk was when I was at the desk making their next appointment. Believe it or not, I got a lot of positive feedback from my clients that this felt more therapeutic for them. Thus, this is how I do it now. Trial and error, but that's the feedback I got.
Great point, Mary Ellen. Great point. So technology may change the nature of the interaction for participants and communication related to the exchange of information, clarity, responsiveness, and comfort. All right. But it's our job to manage the technology and it's our job to make sure that clients feel comfortable and that they feel like they're connected.
Mm-hmm.
Agree. So this is I just love this picture, Mary Ellen. So this picture on the left is like, this is in-person therapy. And what we're trying to do is take those skills and translate them to the figure on the right. Okay. So everything that we do in person and translating our clinical skills, we want to be able to do virtually, like online engagement support, pointing out discrepancies, employing evidence-based practices and best practices, and making referrals. All those things that we do in our regular in-person sessions, we should be able to recreate in our telebehavioral health sessions.
Absolutely.
Okay. So let's see here. So this is a new article by Groom. Mary Ellen and I love this article, and they're really the first that talks about a telepresence. So we take the word presence from the counseling literature, and then we look at telepresence. And so she really looks at defining it as a mental state in which a user feels physically present with a computer-mediated environment. And telepresence is the patient's, caregivers, and clinicians' experience realism during the telehealth session and it's built on connection, collaboration, trust, support, and the clinician's skills as acting as the technology mediator. And when we talk about that, we'll talk about a little more detail. We're not talking about you being a technology expert.
No, not at all.
But
no,
it's
just enough.
our job to be able to mediate the technology. So, Mary Ellen, you want to go over this chart that she came up with, or diagram?
Yeah, we could go over this. So, in the center, of course, is this concept now of telepresence. And as you can see by the red circle, there's 6 elements that we have to be versed in, mindful of, to be able to create this experienced realism, right? To create this telepresence. And those are, as you've mentioned, connection, technology mediation, trust, support, and experienced realism. And so what we're going to do in these next slides is to break down these 6 elements one by one and talk even more in depthly as to what each of them means and how that's represented, or how you can display it as a part of your own telepresence.
Great. So first one is connection. And there's a lot of bullets here, and we can go through all of that in a lot of, we don't have time to go through it in a lot of detail. But for me, Mary Ellen, you can pick yours. Mine is like, you got to be aware of that your attention may be divided.
Yes.
Between, do you want to comment on that?
Yeah, I have always taught, when I teach telehealth, if you're doing a family session or a couple session, have everybody sit in a different room on different devices, right? Because the last thing you want is a couple having a heated argument while sharing an iPad. I have, again, learned the hard way. It gets tossed, and I'm stuck looking up at a ceiling fan while I hear them fighting in the background. Getting everybody to kind of have their own space, and then me driving the bus as the clinician can monitor if somebody needs to be muted, if we need to call a timeout, things like that.
So also with connection developing, if a patient's uncomfortable, try, it seems like, I think you're with folks are going to hear a theme here that you're much more directive in providing services via telehealth. Would you agree
much
with that?
More verbal, much more directive, also more patient. I do want to address this very first bullet. Again, we got a lot to go through, but just to demonstrate patience, telehealth is not cookie cutter. It's not for every clinician, and it's not for every client. However, don't assume those who are novices or not from the generation of computers can't participate. I do this thing where on a Friday, if I have somebody new for a couple weeks, 10 minutes, that's all we need to help you learn how to use your computer, so that when it does come time for your therapy session, we don't have to deal with that. Is it billable? No. But my 10 minutes of patience 2 or 3 weeks in a row is going to help me in the long run with this person that is in need of services.
And build their connection. Absolutely.
Build that connection. Absolutely. Build that connection.
And then trust. And I think the first point here is really important. And I know I struggle with that, is looking in the camera, not in the screen.
Yeah. One of the tips we tell people is, if you have even if you have an in-computer camera, if you put a little colored dot next to the camera, and just every now and then have your eye gaze over to that dot, it will present as eye contact on the screen, because it does transmit differently. As you can tell right now, I'm looking at my computer, my camera. Now I'm looking at my computer screen, so you can clearly see the difference, and you've got to be mindful of that when you're doing treatment.
Okay.
I think what's important too with trust, Nance, is to remember that the computer screen is a magnification, right? It's definitely this magnifier. So how I present is really going to be enhanced to the folks that I work with. So if I, want to express emotions or feelings to help engage and build that trust, I need to be mindful on how I go about doing that.
Yeah, great points. Let's look at support.
Mm-hmm.
And I think this is the third bullet down. You were talking about that researchers found that video screen invites intensive gazing. And so while patients are speaking, observe and provide supportive statements to help with the verbalization of issues. So that
Of their issues.
encouragement, the nodding your head, all of that.
Absolutely. And it is a lot of reflective, a lot of supportive statements. Quite frankly, when I only did face-to-face sessions, I would do about 8, maybe 9 a day in a 12-hour day. It was long days, but it was still 8 or 9 sessions I would do because I talk more and I use my senses differently for telehealth. Quite frankly, 6 people a day is my max. Is the limit. If I have to do 7, I can definitely feel that it's not fair to that last person, so I don't do it.
Okay, great points. Collaboration.
Collaboration is easier than people realize. We do have to make some deliberate attempts to collaborate with the folks we work with over this medium of telehealth. So one of the ways I teach people is, if I was in my office, I have a filing cabinet. And if I want to collaborate with you and do some psychoeducational or work on, a therapeutic process with you, I get up, I go to my file cabinet, I pull out the material, and we sit and we do it. Because I'm using a computer, I can still do that. I just have to be really careful about breaking confidentiality of not only other folks I work with, but my own information. So a quick example is I have a folder on my desktop entitled File Cabinet, and my most frequently used documents sit in that folder.
So for example, like craving, helping someone with craving.
Helping someone with cravings, right? A wellness wheel. My first 3 steps of AA. Pull that up, right? And I pull it up even before the session. I try to get an idea of where we're going to go so that I limit the amount that I may accidentally risk by saying, hey, hold on, I've got this great thing and I'm going to share a screen. And so and then I bring that material in though through share screen, just like you're doing with the slides. And you and I are demonstrating collaboration right now. It's no different. We're taking a document and we're going back and forth.
Great points. Great points. So realism and let's see here, the title is sort of messed up. And emotional consequence. I really think it's so important to be able to, we are together even though we're in separate rooms, we're together and we're working on what we've agreed to work on, and that we as clinicians are responsible for setting the stage for that.
Yeah, believe it or not, I often, especially newer clients, will thank them for allowing me into their home. Again, right? Certainly not anything I would ever think to do in a face-to-face, but it's the same but different, right? Thanks for coming to your appointment. Hey, thank you for inviting me into your home. Even sometimes too, if there's something in the background, a picture or something, making comment and just that couple of minutes at the beginning of a session, sharing that moment with them. Again, like I shared too, if I have someone who is uncomfortable or maybe a little paranoid with where I'm coming from with my session, I'll move my camera around. It's just this interaction that just builds between the folks I work with by what I do, what I ask, what I offer, all through the computer. I want them to feel safe.
Absolutely. And then the technological mediation.
Yeah, that kind of goes on to my the example I gave earlier with my wonderful little 83-year-old woman who every Friday before we even got to the assessment was teaching some computer skill. We don't have to be computer analysts. We need to know enough. But what's important to know is I use Zoom as my platform. I need to know what Zoom looks like on a computer compared to an iPad, compared to a telephone, because the directions I'm going to give somebody if they're struggling with the technology, how to turn off the mute button or how to get their camera back on. I need to know how to walk them through that. I need to stay calm, right? Like we said earlier about the reluctant provider. I'm a mirror. So if I'm, hemming and hawing about technology issues, the folks I work with are going to pick that up and they're going to feel that projection of negativity. So I need to know enough to get by, but also I need to know how I use the platform I'm using and be an expert in that platform or that modality before I start bringing it into sessions as well. If I don't know how to use the share screen, don't try to do it in a session. Learn how to do it before you use it.
Good point. There's also, let's back up here. I think one of the things that I think is important is making sure that, we don't get so worried about the session that we're more focused on the clinical usefulness rather than even if we have some technology kind of crisis or whatever. It's like,
yes,
it's okay. We can work our way through it. We'll get better at it. And that we reassure the client that it's okay. And we may have to switch to a phone call.
Yeah, we always have a plan B and a plan C.
Yeah.
Right early on in meeting with somebody, when you start doing teletherapy with them, it's, what's your phone number? Here's my phone number. If for some reason we lose connectivity, please log back in. If I go away, just sit there, I'll be back. And if there's a problem, I'm going to call you. Because I don't want to go from a great session focusing on the clinical issue and focus so much on the technology that I lose, the purpose of the meeting for the folks we're working with.
Yeah, great point. So we're gonna add this other piece in, and it fits with Groom's definitions of how to create a telepresence, and she talks about. So we just went through the technology mediation, but when we look at many of the state and national associations and what they're requiring regarding doing telehealth, one of the things that's that we see with many of the like MSWs, NASW, AAMFT, APA, ACA, or LPCs. You look at this, and one of the things they say is demonstrate your competency with the technology. And so and I always crack up, Marielle, I'm like, what in the heck does that mean? Like, how do you put that in sort of really helpful behaviors rather than just saying, oh yes, I'm competent with the technology. And so we've listed some of the things out here that demonstrate that you're competent with the technology, right? That you can help troubleshoot, you can help and advise patients. Like Mary Ellen said, you've got to know what Zoom looks like, or whatever platform you're using looks like on a phone, a laptop, a tablet, so you're able to give instructions. And then also you're able to understand the reason you made the choice you did with the particular platform, and what it has to do with privacy, security, and the federal confidentiality, 42 CFR Part 2 protections.
Yeah, very, and that even goes into probably a conversation for another day, another topic,
Yes.
but the legalities of the informed consent for
Yep.
teletherapy being different than the informed consent for face-to-face,
Right.
and being able to explain to the folks we work with, right, I use Zoom because it's HIPAA compliant, and this is what that means.
Yeah.
Our colleagues in Florida have created this wonderful form where a clinician will watch some YouTube videos that the company created, and have a couple practice runs with a supervisor, and then they have to demonstrate their competency to get signed off so that they're allowed to do telehealth from their home, which I just thought was a wonderful thing that they turned it into a policy procedure piece so that it's not just anybody can do it.
That's a great example.
Yeah.
So there's some other points about the use of technology. Some populations maybe much more comfortable with technology. Children in general like to report that it's a novelty. And then you can, some folks, especially patients with anxiety, report less anxiety with telehealth. That's a study that was done a while back. And the other thing is that a patient's perspectives is best captured in their primary language.
Yes.
And so, using, demonstrating the communication with synchronous video is less problematic than asynchronous communication, especially for folks with English as a second language. So, and Mary Ellen and I are heading into talking about some tips. One of the things we're going to lead you into now, it's the little things over and over and over again. One of the things we want you to be thinking about when we're talking about tips is how to set up your office, a typical appointment length, regular schedule of appointments, how you do that, the time frame, and thinking about how you set all of this up actually relates to clinical issues. It actually relates to security, trust, and confidentiality.
Yeah, it was real interesting. You've heard me share, Nancy, the experience I had where every morning about 8 o'clock in the morning is when I send out my Zoom links to my daily appointments. And there was one particular morning where I had like an 8:30 dentist appointment. And I figured I would send the links out when I got home. When I got home, there was a number of messages from about half of my folks that day. Are you okay? I didn't get the link. Do we have an appointment today? It really opened my eyes to that security and that they felt that assurance that we were going to meet today around the 8 o'clock hour. And when they didn't get that, they became worried that either they were wrong or something happened to me or that something was off. And to me, it really demonstrated how it was that little thing that folks recognized had an effect on them.
Absolutely.
Yeah,
absolutely.
had no idea.
And we all know as clinicians, structure brings trust and security and safety. And this is what we're talking about when we're talking about structuring telehealth services.
Yeah.
And we are going to go over establishing a screen side manner, little tongue in cheek, do's and don'ts, setting up your office space and serving as a role model. Region 6 ATTC has some great tip sheets that you can download and use. So those are available for you as well. Okay, so with video, words, and body movement, all those things replace in-room behaviors like a handshake. So everything you do is about engagement and welcoming people, and how do we set all those things up? So if we would shake hands with people when they came to their sessions, what do we do instead of that?
Yep. And you've heard me say, I see with my ears now, and I listen with my eyes.
Yep.
I'll say that again. I see with my ears. I always give the example of the gentleman I work with who had a horrific abuse history. And when he gets anxious, he starts to play with a drawer that is under his desk. And so I hear that, and I'm able to observe and bring it to his attention. Believe it or not, eyebrows are a great body movement that can help you figure out what's going on, as well as shoulders, up, down, move, twitch, things like that.
Okay, great. So let's do screen side manner. We've talked about already, Mary Ellen, so I don't think we have to go into much more detail, and we'll go through this pretty quickly because we've got about a half an hour left. But you're going to be much more directive than you thought. So you're going to be balancing your facilitative and directive language. You know, so you may say things like, oh, there's a lot of background noise going on. Can you move to a different spot for our session? And the person may be like, nope, I can't. And be like, all right, how are we going to manage that? What's going to work best for you? Right. And so helping and directing the patient or client, very different in some cases than sort of typical outpatient counseling sessions.
Absolutely. Yeah, you're gonna, move your camera down. Can you hear me? Can you go someplace else? All different stuff that you would never think to even have to.
Mary Ellen and I really believe wear solid colors. You can see we role modeled that today.
I consciously have to go, okay, I've got some great patterned shirts that I don't get to wear.
No.
It gets distracting.
Making sure that you dress professionally, nod your head, lean forward. And this comes out of some of the articles as well. It's not just Mary Ellen and my rules. If you look at some of the clinical articles, they also have some real specifics in there about making sure your face takes up, this comes from Don Hilty, your face takes up 2/3 of the screen. In other words, you don't want to be so far back, right, Mary Ellen?
Right, that the person feels you're detached, or too forward to where it becomes uncomfortable and overwhelming.
Yes.
It's a nice balance.
Act slightly more animated, stay seated, don't pace, adjust your camera so your entire face is visible. Facing forward. Now, some of this is like, you're like, gosh, Nancy and Mary Ellen, duh. But it's nice reminders, all right? About fidgeting or tapping or rocking back and forth. Mary Ellen reminded me of jiggly or jangly earrings. I have to be careful of that.
Background noises. I've got my girl every Thursday at 5:30. The train goes past her apartment, and we hear it. And we have to be mindful. And sometimes I have to work it into the session and be mindful of it. The eating and drinking, Nancy, I'm a queen for always having a water or a coffee. Like I mentioned, the screen is a microscope, so it covers my face and not appropriate. The chewing gum or ice or hard candies. Again, since everything seems bigger on the screen, all of these little things that we may do in a face-to-face session where there's physical distance are negatives in a teletherapy session.
What do you think about video camera shaming?
It's real interesting. It's not something that I ever heard of before until COVID, and it really made a lot of sense. And we have found workarounds. So video camera shaming, especially for those that we work with who are mandated, and we say you've got to be on camera. It takes time and practice to be able to see yourself on camera. It's very uncomfortable. Never mind for clients, clinicians don't like it. A lot of people are it's like hearing your own voice, right? Nobody ever seems to really like that. So video shaming is forcing that person to be on screen. We don't want to shame them. So one of the workarounds is colleagues of mine who do groups will allow the person to log on, show their face, but then turn the camera to point towards their hand or like their knee so that they know that they're present there, but that it's not their face on the screen. I have a client who does log on through her phone. She puts her phone up and shows me her ceiling fan. That's how she's comfortable. That's where she feels the ability that she can share some heavier issues, heavier abuse issues, and doesn't have to look at me and I'm not forcing her on the screen.
Yep. And then also we know that people, especially during COVID where folks were stuck at home, you know, people were embarrassed, laundry on the bed,
Yep.
you know, chaos, a lot of toys, kids running around, all those type of things. And it's like, we don't want to video shame people. And Mary Ellen's brought up several different suggestions people can use to demonstrate that they're there, they're participating, and that they're not embarrassed, because once again, we want them engaged and we want them there for treatment. Do you want to go quickly over some of these, because I want to make sure we have time.
Just to be mindful of your own grooming issues. You know, Nancy and I always laugh about our glasses, not just because of the glare, but I have been known to leave a lunch crumb or two on my glasses and make sure that that's removed. They could be a distraction. Have nothing around you, quite frankly, your phone, anything that could interrupt or distract you. It's really important, but also these are the things you have to share with your clients. So think about how you're going to express to them. One of the ways is us modeling appropriate behavior. But again, we talk more with teletherapy. So you may need to go over some of this stuff with the folks you're working with in an appropriate manner to help them understand the importance of no distractions or I can't see very well type stuff.
Right. Also, you know, this used to be a bigger issue. I think people have gotten a lot better with it. Although I do see newscasters or people, experts online still like, you know, seeing the shadow faces and, you know, I watched a guy the other day having like a fire alarm, whatever, like coming out of the top of his head. And, you know, it was distracting. So I didn't listen to what he was saying. I'm like, why wouldn't you change, you know, how you look online and blah, blah, blah. But Mary Ellen, can you talk about the Alexa type device?
The Alexa's huge. Reminding the folks you work with, whether it's a Google in-home Alexa, any of those listening devices, to not have them in earshot in your office or where your client is doing their session from. Those are listening devices. They can pick things up. You know, hypothetically, I have a question, could wake up Alexa. Now on the Alexa app on my iPad, I'm able to see everything my kids ask Alexa when I'm not home, whether it's what song to play or how to pronounce something. So that could risk confidentiality, trust, and safety with the folks we work with. So we don't want any listening devices at all, anywhere.
Right.
I think another really important thing too to mention is the consistency and very limited distraction behind you, because folks will use that to deflect and not deal with their issues. There's new research out too that talks about if you do hybrid, try to have your face-to-face office be similar to your virtual office. So that also increases the level of comfortability and safety with the folks you work with. The consistency is huge.
So make sure that it's the little things again, that it's private, your office, the way you set it up, professional, warm, good seating, adequate lighting, soundproof. I'll go on to the next one. This is not a picture of me, but we
That
have
was you yesterday. No,
we do have to work or serve as a role model.
yes.
And so we have to turn off our phones. We have to dress appropriately, and be really careful. We're going to talk about this in more detail, Mary Ellen, so I'm not going to go into it much
Good.
here
Mhm.
about avoiding self-disclosure, chatting. We're going to talk about that in a little more detail coming up. But in Mary Ellen, do you use a virtual waiting room?
I do. That's part of keeping the boundaries with my folks.
Okay.
If somebody, if they showed up at my office 10 minutes early, I personally would not bring them up until the hour. So just because they are in the virtual waiting room, I still wait for the hour to bring them into their session. It's that consistency and the boundaries.
Okay. Great. So,
Disinhibition.
yeah, I know this is
Huge.
one of our favorite topics.
Yep.
So a long time ago, Suler and Suler came up with this term of disinhibition or online disinhibition effect. And certainly we see that today even stronger, that people say stuff online, on social media, that they would never say to somebody's face. And it also impacts clinical services. And that's one of the things we have to be really careful of. And we're going to talk about this from this disinhibition effect from two different perspectives. We're going to talk about it for the flexibility or the temptation to make services more flexible. And then also the assumption that, oh, if I'm doing services online, I don't have to be as worried about having boundaries and boundary crossing violations. Aha, not
You
so.
need to worry about them more.
Yes, have to worry about it more. So, Mary Ellen, you want to do this one?
Yeah, just with the telehealth is so flexible. I could be visiting my friends in Florida and working. I could work anytime, right? When COVID first hit, it was do what you need to do to get your people seen. So we were working, all different hours. Those are all kind of bit people in the butt with boundaries. All right. My office hours are from here to here. Just because I'm home and I have a computer doesn't mean I am a 24/7, 7-Eleven therapist, right? There's a time and a place. So it really did, and it can create some assumption from the client side that we're just sitting at home or we're just at the computer. So we really have to be mindful of this disinhibition effect and stick with those boundaries. Like I mentioned, the waiting room. Another risk is that they perceive us as a buddy or a friend. I see one person on a Friday, and some days, quite frankly, the last thing I want to do is get dressed up and come down to my basement and have to be professional for 50 minutes. I would love to be professional with just a sweatshirt on and a ball cap, but I can't. I have to be sure that I'm going to be professional Mary Ellen for 50 minutes that day, even though the rest of the day is going to be personal Mary Ellen, who is going to talk on FaceTime to their sister or talk with their friends on the computer. I have to be sure I don't cross that line because they can be really slippery.
Yep.
And
So
gotta stick with those boundaries. Yeah.
Boundary recommendations, maintain professional hours and respect timing of sessions. Ensure private, consistent, professional, culturally sensitive settings. About, we have this when we do in-person counseling where we run over, where we have the doorknob disclosures, as I call them, as the client's going out the door. They say, oh, by the way, I need to tell you this. All those things happen in a similar fashion with telehealth. and it's our job to be able to manage it. And actually, I think it's harder in some ways.
It is. Once we started to integrate technology into therapy, we started to get more emails as clinicians from our clients
Yep.
because they knew we were more accessible. So it really does kind of become this challenge of, what's appropriate, what's not appropriate, but also how we appropriately discuss these issues with the folks we work with.
Definitely. Okay, so now there's steps, we're moving into steps that you can take to enhance your telehealth skills. And since clinicians lose some connection through touch and gesture, we must heighten our verbal engagement skills through active listening, reflection, and use of empathic statements. You agree with this?
Absolutely. I think I've mentioned it a few times today, right? It's much more verbal, it's much more descriptive. I hear you feeling sad. Are you sad like a cloudy day, or are you sad like it's a really heavy duty, rainy, dark day? And little things like that can sometimes help with getting a deeper connection with the folks we work with.
Do you find yourself having to talk slower, or
Yes.
Okay, you want to talk about that?
Yeah, some of that comes, again, not cookie cutter. Each person is different, but there is in some connections a delay in audio, which can become frustrating. Everybody learns differently, right? There's some who are tactile, auditory, visual. So for some folks, being so auditory focused, we just go a little slower. We just have to be mindful of that they're understanding and that we're all on the same page.
Yeah. And then look out for disinhibition effect. I think it's really true. And I think one of the things that's important is that you don't tell yourself, oh, it's online, I can't get myself in trouble. And then, as we know, people fall in love online all the time.
Well, I think what's interesting too is some of them want to become our friends. I've had clients, right? They trust us. We're important to them. So now we're in their house, and now they want to show me the new picture they put up in their living room, or the new project they did, because the positive reinforcement I give them makes them feel good. So that's where I say that slippery slope, because all of that positive reinforcement is great, but are they taking it? How is it being taken? We've got to be aware of that.
Yep. And then people that are clinical supervisors, certainly it's with newer clinicians who are using telehealth, being too casual with clients, similar to the situation you were just describing. Scheduling appointments outside of typical business hours, or while in vacation, or in public areas. Those are all red flags. Would you agree?
Yes, absolutely.
Okay.
Yeah, I mentioned about the emails getting more comfortable. I had to have the conversation. A woman was emailing me at 2:30 in the morning with panic attacks, and finally I just said, what am I supposed to do with this information? What would help you? What do you need me to do with this? And they said nothing. I just was using it as a journal, and we had to talk about what was appropriate and not appropriate.
Confidentiality, and who can have access to the email, and all of that. Yeah, absolutely.
So I will stress, and I encourage everybody who's here, if you have not Googled your personal name and your professional name in more than 6 months, please do that, because that is what your clients are seeing, because trust me, they're Googling you.
Especially about, I'll tell you, especially if they're millennials or Gen Z. I can tell you, my son, who's a millennial, doesn't go anywhere, or gets his hair cut without checking with people.
Yes.
And checking them out and seeing what their
Google what comes up,
what their ratings are.
Yeah.
So I want to quickly just highlight these guidelines. There's a great guidelines that are available. The American Telemedicine Association and the American Psychiatric Association joined together in 2018 and came up with guidelines. You can easily find those. They have not been revised yet. And you can see they talk about legal and regulatory issues, standard operating procedures, technical considerations, and clinical considerations. American Psychological Association also has guidelines regarding how to conduct groups online, and that's available easily to download as well. And then Mary Ellen, before we head to the end, do you want to just quickly go over this? And I know it's more than quickly, but this is really important for folks.
It is.
Do nothing else.
Safety first, right? Please, no matter where your folks are, we make sure they're alert and oriented appropriately. The technology check. Can you hear me? I can hear you. Can you see me? Making sure the person has the phone number. Also knowing the location where your client is at for the session, and the emergency contact information. And I'll give you one of the methods behind the madness here is, I live in Northeast PA. I've got a gentleman who is a traveling salesman, and he used to think he would hide his car at, like various places for his sessions, until finally I just said, listen, God forbid something happens, I can't get help to you. So we had to come up with a plan for him. He lets me know what exit off of what major highway he took, and then what major gas station or rest area he is at, even before we start the session, so that if I have to get emergency information or emergency personnel to him, I could give them an exact location.
And you do this every time?
Every time.
Session.
I see Bill once a week, and once a week it's more, hey, Bill, where are you at today? Now, we've been seeing each other long enough where he'll say now, well, at the Sheets at Mifflinburg, or, hypothetical town. And so I know that now. But yeah, we do it every session. Obviously my folks who they log in week after week, and I know what their dining room looks like. I don't say, what's your address? I know they're in their house. But
Right.
as far as in case of emergency, don't assume it's going to be the same as a face-to-face. My college kids, when they're in town, they're usually, their mom is their ICE number if they're at home. But when they're at college, sometimes these kids are 3 to 4 hours away. PA's a big state. They need to identify somebody on their campus who's going to be their emergency contact, because mom, 3.5, 4 hours away, isn't going to be real useful if I have an emergency with my guy out at University of Pittsburgh.
Great point. Thank you. So you can see here, telebehavioral health is equivalent to in-person care. The research base on mental health services is extensive with telehealth. It's growing for SUD treatment, especially opioid use disorder treatment or medication or MOUD. Patients like it. Clinicians could be initially reluctant. Engagement, therapeutic alliance, and presence is always important, and it's the same but different. In telehealth sessions, we learn to create telepresence. There's telehealth tips that you can follow. Make sure you think about this online disinhibition effect. I always like people who go, oh, I don't have that. And it's like, oh, yes, it impacts everybody. There's national guidelines that exist, and there's resources for training. We offer lots of different trainings with Mary Ellen, and we're offering an academic course as well. I think we want to do these two really quickly, and then I have one new slide, Mary Ellen, and then we'll take questions.
And I've got one quick comment too.
Okay, good.
My quick comment just is that, you and I are offering a broad sense of teletherapy.
Yes.
It is different with adolescents. It is different with children. There are certain special populations that you're going to work with. Please, if you do work with those populations, medical assisted treatment people, there's information out there, or let us know, and we can help the best we can. But this is a broad topic here.
Right. Now, we know not everybody's I don't want to do that kind of work.
Right.
Okay. Well, but who do we want doing the work? We need to have people trained in doing this work. And it's not going away. We hope not. And even if you decide not to do telehealth services, how do you talk to your clients about it if they ask you questions about it? And do you have someone that you can refer them to who is doing telehealth? You know, just because it's not something we're like, oh, doesn't fit, it's not me, that's fine. But we also want to make sure that we have somebody that we can refer folks to.
We need to have people that we can refer folks to.
Now, latest study, University of Washington. Many of your folks may know Dr. Frost, but recent study done 17,182 VHA patients about access to BUP. And they tested out video and telephone and patient retention. And really what we're talking about here is, man, we have to make sure that the access to telehealth does not go away, because it keeps many folks connected and receiving their medication and receiving their supportive services. And we're getting good results on video and telephone. All right, and that's this study just came out. You can see here on JAMA Open Network. As I was putting together this our proposal, I saw this study, and we just want to make sure that folks have access to video, to in-person, to video conferencing, and to telephone. So, Riley, we are happy to address any questions you have. We have about 8 minutes left. Sorry about that.
No problem. Okay, so the first question is, do you know of any particular communities who experience disparities in consistent cell phone or internet access for telehealth?
You know, when I look at that data, 10 years ago, we did, and several studies have been done. One has been done in San Francisco, I believe, and then one was done with Maxine Stitzer out of Johns Hopkins. And they discovered that everybody had cell phone access, but not as much smartphone access. But now when I look at the data, there's recent studies out that show 85% of the folks have access to smartphones. And so the disparity has lessened. And that's why, even though Mary Ellen and I didn't spend as much time talking about that today, we're big believers in the use of telephone. And because almost everybody has access to a cell phone, and you just have to know that the phone numbers may change a lot. And so we think that if you had to do it over computers or tablets, there'd be a huge disparity. But we think now with the sort of buy as you go or use as you go smartphones, it's really increased. And Mary Ellen can attest to many of her folks do their sessions on their phones.
Yeah, that, and you know what too, we've also done a lot of things thinking outside the box, bringing peers or therapists on the street down to localized area, well, for example, where a lot of the homeless people hang out during the day, and we go to them and provide them with the laptop, or not the laptop, the iPad, to have a session with somebody. So again, there's some disparity, but there's also been a lot of great thinking outside the box, and how do we go to them? And again, right, the onus is on us, as opposed to
or how do
trying
we pay
to
for phone cards and upping minutes and all those kinds of things. Yeah.
Mhm.
Okay, so the next question is, how do you deal with confidentiality issues? And have you had any issues with hackers accessing your interviews?
I have not had any. I have many layers of security. For example, my home computer is different than my work computer. I pay for a virtual private network on my own internet line at home, so that another layer, the layer of HIPAA compliant modality is Zoom. I use Proton Mail. It's just having different. I could never ever promise 100% confidentiality, but what I do is explain to my folks the things I have in place to enhance security and privacy of their information and my systems.
Right. I think Mary Ellen makes a really good point. It's not the equipment that's HIPAA compliant, it's the person. So Mary Ellen has put into place policies and procedures that she checks on a regular basis that make sure that she's providing the most secure and private protection for her patients or clients. And that's what HIPAA compliant is about. HIPAA requires that you do processes to make sure that you are taking the best steps you can take to prevent people's privacy and security. The other thing is that there is a Center of Excellence. And of course, now the name, Mary Ellen, you'll have to help me. Mary Ellen and I have taught with them, and they have some great tip sheets available for clients that says how to keep your online sessions private. They have some recommendations for folks regarding 42 CFR Part 2 and private confidentiality, and then privacy and security regarding HIPAA. And Marianne, can you remember the name or?
Yeah, it's the Center of Excellence of Protected Health Information.
Right.
PHI. There's a wonderful quick little video. Actually, I send it to my people before we even start sessions so that they know how to change their phones and that kind of stuff for privacy. Center of Excellence of Protected Health Information.
Yep, and they have lots of free, they're SAMHSA funded, and they have lots of free samples and tips, and we run all of our recommendations through them. They're great.
Okay, we have time for one more question. Are services being reimbursed by third-party payers, or is cash pay mostly needed?
So this is what's going to happen, right? Right now, we're still under waivers from the pandemic. And I say this to everybody, act like the waivers don't exist. I could treat somebody right now in Illinois, but how ethical and fair is that to the person if I've never been to Illinois, when that's reeled back in and I can no longer do that? It's not proper or ethical for that person. Third-party reimbursement is happening. It'll probably stick around. I think maybe the silver lining of COVID is that a lot of health insurance companies and the government have discovered how useful telehealth is. In the past, it was much more of an issue than now.
Yeah, so many of the states are keeping with audio only, which is what their definition of telephone is. So if you see audio only, they're referring to services that are delivered via telephone, and then services delivered via audio and visual, which is telehealth. And we see most states are going to be keeping both. Some, there might be some states who aren't, but right now the waiver is still in effect, and you're able to bill. And really, I think Jay Shore's prediction about having a hybrid service delivery is really the way to go in the future. And we think, and we know of some providers who are already doing, they do some sessions via video conferencing. They do groups usually in person because groups are harder to do online. And then they do telephone check-ins and sometimes telephone sessions. And they have all those services are offered by the provider.
Okay, thank you so much for your answers. Nancy and Mary Ellen, thank you so much for joining us today. You had a wonderful presentation. Sorry we couldn't get to all of the questions. Thank you everybody for joining us. We really appreciate it, and everybody have a wonderful day.
Thank you for having us.
Thanks.